Hello, my name is Taisha Watson, and I did my senior practicum project on Cauti prevention for Nurse 456 senior practicum at ECPI University, and I did it on the Surgical Oncology unit at ECU Health. So what are CAUTIs? They are catheter-associated urinary tract infections that are the most common healthcare associated infection and the fourth leading cause of HAIs in the acute care setting. They lead to 13,000 deaths annually. The mortality rate is at 10%, and it can lead to bacteremia and sepsis. The longer a catheter stays in place, the increased risk for infection. So by 5 days, you're at 35% risk of a Cauti, and by 30 days, you're at 100% risk for a Cauti. It costs the United States $340 billion annually, and those costs are not reimbursed by Medicare. So this is the presentation that I gave to my nurses on a unit, but before I gave them this presentation, I gave them a 10-question survey asking what they knew about CAUTIs, what the signs and symptoms of CAUTIs were, where to find, if they knew where to find our policy at ECU Health on what to do for Foleys, how to insert Foleys, when to pull Foleys. And everyone was able to tell me that they would go on PolicyStat to find the ECU Health policy for urinary management systems. They were able to tell me a surefire way to prevent CAUTIs, which is pulling the catheter as early as possible, and about how important peritoneal care was after bowel movements, especially for patients with Foleys. So after they did the survey, I gave them a presentation on CAUTIs and how to prevent them, and I did a review of our ECU Health urinary management policy. It is revised and is reviewed and revised each year, and is due to be reviewed July of 2023. And about how our policy talks about how CAUTIs can lead to serious infection and death, and to avoid using a Foley if you don't have to, and the criteria that a provider, like the provider, needs to state a clear indication on why a patient has to have a Foley when they order a urinary catheter for the patient. Our policy recommends to bladder scan and do intermittent in and out catheters for acute retention. That's the best evidence-based practice to prevent CAUTIs. And of course, our staff has to show that they are competent by placing a Foley with a preceptor before they can do catheter insertion on their own. With the survey, they were also able to tell me that we had modules on our learning center that's on the internet, and also on our Mobies that's also on the internet, if they wanted a refresher course videos to watch on certain CAUTIs and certain Foleys and Foley management, and if they needed a checklist on what to do with inserting a catheter. On our unit right now, we are actually doing extra documentation for every time a patient with the Foley has a bowel movement. We have to document that peritoneal care was given and who assisted us with the peritoneal care, as a way to keep up with and show documentation that Foley care is being given as needed for patients with Foleys. So I also went over it during my presentation, things that we should do to continue to prevent CAUTIs if a patient has a Foley, maintaining a closed system, making sure that the seal isn't broken between the drainage bag and the catheter, making sure the tubing isn't kinked, making sure there's no type of obstruction, using alternative devices. We do have those on the unit. using a Foley buddy if you do insert a Foley, if a Foley is ordered, and of course, repeating the bladder scan every 4 hours. If the volume is greater than 350, then you would do an in and out catheter. I also went over the removal and post-removal protocol, because of course, removing the Foley as soon as possible is the best way to prevent Cautis. So I went over this pathway and I showed them where to find it on Polystat, which is on our facility's intranet. This is also on our facility's intranet. It's a Cauti prevention bundle, and it goes over the same things that I talked about in the presentation, making sure that we have an active order with appropriate indications for the catheter, discussing with the charge nurse or the provider if we feel that a catheter, if we're not sure if the catheter should be pulled or not, assessing every shift and every day the need for the Foley, making sure the tube isn't kinked, making sure that the drainage bag is not touching the floor, making sure also that if we do place a Foley that we have a Foley buddy. I gave them links on how to find on Polystat our urinary management policy, and also links to extra information if they want to refresh a course on inserting the Foley. We have a checklist on Mosby's. We have the procedure on how to insert a urinary catheter on Mosby's, and also the maintenance, doing the peritoneal care, making sure the tubing isn't kinked on Mosby's, and that's all on my facility's intranet and on Polystat. I also gave them pictures on what the alternatives for indwelling catheter are. These are external catheters, they're called on our EHR. And the condom catheter is for patients who have a penis, and the PureWick is for patients who have a vagina. Of course, I also reminded them that peritoneal care still needs to be done, and we still need to assess for skin breakdown using these external catheters, but they are a way to prevent Cauti, but still manage a patient's eyes and nose, prevent further skin breakdown if they have like a sacral ulcer, and to prevent moisture-induced ulcers. If a patient is at risk for ulcer due to frequent voiding, if they have a risk for skin breakdown because they're always wet, is the way to prevent that. I also go talk about new interventions that we could do, like forming a Cauti prevention team, or doing weekly audits, or having a bedside checklist for Foley insertion. I gave them a picture of a bedside checklist that was used in one of my 10 articles that I used for research for the project, where they go into depth, because our EHR doesn't go into depth. It just says, is Foley care done, yes or no, and what's the reason why the patient has a Foley. So it's not as in-depth of this checklist. So I gave this as an option that we could start using on our unit. And of course, I gave them some things to remember. That nurses have the most contact with patients, and so that we always have to assess and make sure that the Foley is appropriate, and pull it as early as possible if the patient doesn't need it anymore, because that's the best way to prevent Foleys. Maintaining a closed drainage system, using clean tape technique, and of course, hand hygiene is very important, using the standard universal precautions. So after the presentation, I gave a 5-question quiz, and most of the 15 people who participated in my presentation scored well on the quiz. But one thing that tripped them up was the signs and symptoms of a Cauti, and a lot of people chose fever and blood in the urine. And blood in the urine usually might denote some type of trauma or something else going on with the patient's bladder, urethral trauma or something like that. It is not a sign and symptom of Cauti. So fever, and then doing a positive urine culture is usually the way to diagnose a Cauti. So they need a refresher on how to spot a Cauti and what to look for if you suspect a patient has a catheter-associated urinary tract infection. But everyone knew that the earlier you pull the Foley is the best way to prevent Cautis, and that also that daily maintenance needs to be done, and also after every bowel movement. So everyone got that right, and everyone, I wanted to stress that Medicare does not reimburse Cautis if they develop, and so it's on the facility if a Cauti does available, because they are preventable, and also that it could lead to mortality. So we definitely want to avoid them. And so everybody was able to answer those questions correctly. And then here are my references of the 5 of the 10 articles that I use for my research, and I use these main 5 for my presentation. Thank you so much for being with me. You have a good day.